All right, this is going to be Chapter 15, the Respiratory System, Part 2. And covering quite a bit of area in this, pulmonary ventilation and a lot of clinical notes, respiratory system interventions, pulmonary function test, gas exchange, chronic respiratory system disease, upper respiratory infections, pulse oximetry, carbon monoxide poisoning, arterial blood gas measurement. 3 steps are involved in respiration. We have pulmonary ventilation, we have gas exchange, and then we have gas transport. In pulmonary ventilation, this is pretty much the movement of air in and out of the lungs. Air comes in, higher concentration of O2 of the air that's coming in. As far as the blood returning, there's a higher concentration of CO2, and it goes from a higher concentration to a lower concentration and vice versa. It pretty much diffuses, gas exchange diffuses at 2 sites. One site it diffuses is right here that we just talked about. The other site is actually down in the capillary level to where the CO2 that's being produced by metabolism of the cells is increasing its levels in this area here, and the hemoglobin molecule and the oxygen pressure that's attached to it is higher as the blood is coming into this way. So again, O2 level higher here, higher concentration to a lower concentration, higher concentration to a lower concentration. Fortunately for us, the hemoglobin molecule transports 2 different types of gases. It will transport oxygen, and it will also transport carbon dioxide. Then gas transport of oxygen and carbon dioxide in the lungs and tissues. Pulmonary ventilation, physical transport for air in and out of the respiratory tract. We pretty much consider this the respiratory cycle, which includes inspiration and expiration. And then we have alveolar ventilation, maintain adequate ventilation in and out of the alveolar sacs. And this is the smallest areas, actually, in the lungs. Capillaries are running through here, and the air comes into this area and will exchange into the capillary alveolar membranes. Factors that affect airflow to the lungs, obviously a pressure gradient, so we have to have a higher to a lower pressure from an area of higher concentration to an area of lower concentration. This can be problematic sometimes because of loss of oxygenation at the alveolar sac, volume in the lungs. So this is dependent on the volume in the pleural cavities. If we do not have the ability to move gases across the alveolar sacs, we will not get gas exchange. Adequate pleural fluid, sticking of the pleural tissue to the thoracic walls affects the amount of volume of air. And very quick example on this. Let's say that an alveolar sac was collapsed on itself and we couldn't get surface area of air to move through there. So in that case, that entire area would be a loss of surface area. Diaphragm. When the diaphragm contracts, it flattens. So at the point it's relaxed, it actually looks like this. Whenever it contracts, it kind of flattens out. Well, that causes negative pressure and allows for ventilation to occur. Rib cage, external intercostal muscles can be inflamed. These muscles get inflamed, and this can decrease your ability to actually bring air in. It's called costochondritis. And then compliance, resilience and ability to expand. So if the lungs will not expand from whatever the reason, then compliance is hampered. And this is figure 1511 in your book. This is talking about inspiration, and the easiest one to probably look at is the one on the bottom here. That the diaphragm during relaxation is kind of bowed up here. Whenever it contracts, and when it contracts, it shortens. That's all muscle does. So at the point that it shortens, that causes negative pressure to occur in your lungs, and air comes in to both lungs. And during that inspiration, we get gas exchange to occur at the alveolar sac. The gas exchange occurs and the CO2 is dropped off, and in that split second, whenever the diaphragm relaxes again, there's more pressure, the lungs have compliance to them. They have the ability to expand and contract, and the air goes out. Clinical notes, respiratory system interventions. We're going to talk about mechanical ventilation, ventilatory settings, pre-hospital mechanical ventilation, complications of mechanical ventilation, and then PEEP. Mechanical ventilation, there are pretty much 3 different cycles that we can actually perform in the various types of mechanical ventilation. There's a pressure cycle, and if we'll just pay attention to the actual word here, it'll help us identify what type of mechanical ventilation is occurring. So first of all, we have pressure cycle. The inspiration is terminated when a certain pressure is reached, and this is going to be a pressure setting actually on the ventilator. So whenever it's triggered, whenever it reaches a certain pressure, then the ventilation is going to stop. Volume cycle. Inspiration is terminated when a certain volume has been reached. So the problem with this is if the lungs doesn't have good compliance, then this can actually pop a lung. So we have to be careful that we have the tidal volume set appropriately on volume cycle ventilations. And then time cycled. Inspiration is terminated and expiration begins at a preset time has expired. So this would be like we want so many ventilations occurring every minute, and that this is going to be time cycled. Tidal volume and pressure can be set on this as well. Clinical notes on ventilation and ventilatory settings. We have a lot of terms in this section. Respiratory rate is pretty much the respirations per minute. Tidal volume, VT, generally is about 10 to 11 milliliters per kilogram. Now, ideally, we like to try to get about 6 to 8 mils per kilogram in a full arrest. This is figured off of something called ideal body weight. Now, this is not the person's normal weight. So if they weigh 400 pounds, about 200 kilograms, we're not going to figure their ideal body weight we're not going to figure their tidal volume off of their normal body weight. We're going to figure it off of something called the ideal body weight. Whenever we get to that section in pulmonology, we'll get the formula to you and get it to where it makes a lot more sense. But these are just general notes. Tidal volume is figured off of ideal body weight, if you could remember that, and 10 to 11 milliliters per kilogram. The FiO2. FiO2 is the amount of percentage that you actually blend into your ventilation. FiO2 is a percentage of oxygen given to the actual ventilatory circuit. PEEP. PEEP is peak end expiratory pressure, and this is measured in centimeters of water. 2.5 to 15 is pretty much adequate, and that's going to occur. You can put that in, pretty much everybody on that, as long as it don't give you any kind of ejection fraction problems. And let me explain this. 20 or more will cause ejection fraction problems, and very simply that is because whenever the lungs are expanded, it reduces the amount of preload that's coming into the pulmonary trunk. So in the overall scheme of things, that's also reducing the cardiac output, or reducing the amount of ejection fraction or ejection of blood that is occurring in your heart. So the more that the lungs have air in them, the less cardiac output you actually have. Controlled mechanical ventilation. Patient is apneic. Patient cannot breathe without, patient cannot breathe between the machine breaths. So this type of ventilation is going to be 100% controlled, and what it'll do is it's going to not allow for any of this patient's spontaneous ventilations to come through. The next one on our list, assisted control mode. Minimum rate is set if no respirations occur within the time allotted, the effort, the minimum amount of ventilation. So you actually are going to have a setting on this thing that will allow you to, this many respirations must be attained every minute. If that is not correct, the machine will actually give you a ventilation. We'll be given the assistance by ventilation from the patient. Tidal volume is set by the machine. So the machine, off of ideal body weight, once the tidal volume is set, will deliver a specific amount of volume in assisted control mode. Intermittent mandatory ventilation, or IMV, offers no assistance, so you can't have people that are completely paralyzed or can't breathe on their own on an IMV. They have to initiate it. For patient ventilations, tidal volume is self-generated. So these people are going to essentially have a pressure trigger on this type of ventilation. So whenever they initiate the actual ventilation, the machine will assist them. Synchronized intermittent mandatory ventilation, it's the same as the previous IMV, only it coincides with the patient's breath. And they also make a mandatory ventilation occur. So the mandatory ventilation generally is given so many per minute. And this is to assist somebody for weaning them off of a ventilator. Like say that they've had pneumonia and you want to keep those alveolar sacs open, SIMV is going to be fairly important to wean them off of the ventilator. And then pressure support ventilations. Used by intermittent positive pressure machines, the rate and tidal volume is dependent on the patient's airway compliance. And the pressure support machine pretty much is going to look both at the pressure that is occurring. An example of this, if the compliance is interfered with, or the actual expansion of the lung is interfered with, you're going to get back pressure. This back pressure will set off one of these triggers. So whenever the pressure spikes to a certain level, the pressure support ventilation or the pressure support machine will actually back off on the ventilation at that point. High pressures can cause barotrauma in patients or damage to the actual lung tissue. Pre-hospital mechanical ventilations are pretty straightforward and simple. They are mostly pressured cycle. Inspiratory and expiratory ratio can be adjusted. And the point on this is whenever we're talking about pre-hospital transport, don't become reliant on the actual ventilator. The compliance of the lung or the ventilation of the lungs, how much air actually would go in them, is best assessed by a BVM or a bag valve mask and a person saying, yes, I got air going in, it hasn't changed. Complications of mechanical ventilation. PEEP, if you put too much peak in expiratory pressure, and this is the amount of pressure that's going to be in the lung tissue at the end of ventilation or the end of expiration, it can actually cause barotrauma, and that's because we can start to stack ventilations in the actual lung tissue. So it had 1100 mils in there at one point, now it's got 15, now it's got 1750, and this exponentially increases every time that they have a ventilation until we get a pop of the lung tissue occurring, which can lead to a pneumothorax or a tension pneumothorax. Tension pneumothoraxes are from a collapsed lung or air being spilled into the pleural space, and then the lung collapses and starts pressurizing a cavity that there's not supposed to be any air in. This can diminish cardiac output. Pneumonia is also a possible cause of this, and oxygen toxicity. We have to have our O2 and CO2 levels balanced accordingly, or balanced nicely. If we get too much oxygen, it's just as bad as almost having too much CO2, especially in like smaller children and neonates. This is especially bad. It can give us symptoms all on its own. Carpal pedal spasms, paramoral circumoral paresthesia can occur, numbness and tingling around the mouth and hands from oxygen toxicity or inadequate amounts of CO2. Clinical note on PEEP. PEEP is peak and expiratory pressure, and we use this whenever we have somebody that has a little extra fluid in their lungs. This would be water or pulmonary edema. The PEEP gives us a little more pressure so that it pushes us back to the interstitial spaces. Now CPAP can kind of do us the same, but PEEP is generally initiated on somebody with an ET tube, and CPAP is generally initiated on somebody that is conscious and can control their own airway. CPAP continuously provides more airway pressure, thereby doing the same thing that PEEP did, driving back pulmonary edema into the interstitial spaces. Modes of breathing. There's two modes of breathing. There's quiet breathing, which inhalation and exhalation are nice, and their inhalation involves the muscular contractions, and exhalation is nice and passive. Both of them are nice and easily fluid in the body. Forced breathing is generally whenever we can note shortness of breath. We have forced inhalation and exhalations are both active. So instead of the passive process of the air just escaping from the lungs, in forced ventilation, we'll see that the exhalation is active, so that they'll actually be forcing air out. They're going to use extra accessory muscles to actually facilitate this. Intercostal muscles, abdominal muscles during exhalation, and this is to actually get the air out. Lung volumes and capacity. First on our list here, more terms. Tidal volume is the amount of air moved in or out of the lungs during a single respiratory cycle. Next term on our list is going to be expiratory reserve volume. The amount of air that can be voluntarily expelled at the end of the respiratory cycle, and that's generally about 1,000 mils. And if you think about that, even after you have had an expiration of air, you can still forcefully move out quite a bit of air after that, and that's what this number is the expiratory reserve volume. So at the end of a normal expiration, you can still add to it. Inspiratory reserve volume. The amount that can be taken in over the resting tidal volume, 3,300 mils in males and 1,900 in females. Inspiratory reserve volume is kind of the opposite of expiratory reserve volume in that whenever you normally take a breath in, if you really forced it, you could take more air in. Vital capacity, the sum of the inspiratory reserve volume and the expiratory reserve volume would be your vital capacity. Residual volume, the amount of air that remains in the lungs even after the maximal exhalation. And you're going to have a certain amount of residual volume in your lungs, and that's going to be about 1,200 mils. Minimal volume, after the lung collapses, the amount of air in the respiratory system would be the minimal volume. And then automatic dead space. The last amount of air inspired never makes it to the alveolar area, and that's approximately about 150 milliliters whenever we look at it. This is a chart, figure 15.3 in your book, that kind of covers some of that. So inspiratory reserve volume would be here. Expiratory reserve volume would be here. The difference between those two is the vital capacity, your tidal volume, overall total lung capacity, minimal volume, and then the residual volume. Take a look at those and be sure that you can differentiate those in a multiple choice question. Pulmonary functions test. Peak expiratory flow rate, which is the amount of expiration that you can actually move across a certain area whenever you're expiring air, should be about 400 to 600 liters per minute is normal. Less than 400 pretty much indicates airflow obstruction, and this would be a reactive airway disease. Things like asthma, COPD, which we'll talk about this one here in just a little while. Things like that, where your lungs start acting like a roach motel. Air checks in, but it doesn't check out. Also on those patients, whenever you are having to ventilate them via mechanical means, you need to put your inspiratory, expiratory times, you need to increase them. The inspiratory times will be fairly short or normal. The expiratory times will be double, if not triple the amount. Gas exchange. Mixed gases in partial pressures is how we kind of look at this. Not a single gas, we have multiple gases. We have nitrogen, oxygen, and carbon dioxide. And if anybody's ever heard me refer to this before, it kind of works like a pie. That each part of this is a specific gas, and that gas will interact. The whole pie would be 100%. So we'll refer to this here in just a second. All right, alveolar air versus atmospheric air. 760 millimeters of mercury is the pressure to a single gas, is its partial pressure. So at 1 atmosphere, at sea level, for our atmospheric sample, it has 760 millimeters of mercury pressure, or 760 torr. Partial pressure is within the circulatory system. So when we talk about partial pressure, we're talking about slices of this pie. And an example down here is PO2. Now, a lot of people have heard, and this what I'm fixing to say is absolutely correct, that your PO2, or the oxygen in the atmosphere, is 21%. Well, actually, it's 20.9%, pretty close. If we round it up, it's 21%. And if we fractionate this and multiply this by 760, and this is going to give us 21% of 760, the answer we're going to come up with is 159, and that's going to be in millimeters of mercury. Now, what is this number? This number is at sea level the amount of gas pressure that oxygen has. So, external respiration versus internal respiration, and this is figure 15.4. So, this is very, very thin. This is the alveolar area, alveolus, and this is essentially attached by a basement membrane and an epithelial cell layer. This here would be the basement membrane. So we're only talking 2 or 3 cell layers thick. Air comes in, and the amount of oxygen that's in the alveolar sac is higher than what is returning in the vessels, which is lower. So oxygen goes from a higher concentration to a lower concentration. The CO2 that's returning is higher than the CO2 here. So again, we go from a higher concentration to a lower concentration. And that's how gas exchange actually occurs. Down here in the actual capillary layers, it's kind of the opposite of what we see in the alveolar sac. That now the arterial blood supply and the oxygen is higher here than it is in the tissues. So due to cellular metabolism, CO2 levels are higher here than they are in the actual arterial blood supply. And our oxygen is higher here than it is in the cellular area. So we get, again, a gas exchange occurring because it will go from an area of higher concentration to an area of lower concentration. And vice versa, CO2, higher concentration to a lower concentration. Fortunately for us, the red blood cell that's moving around in this to carry has hemoglobin on it. Hemoglobin can carry 2 gases. It can not only carry, well, it can carry more than just 2, but the primary 2 gases that it will carry is going to be oxygen and CO2. There is a slight complication whenever we see something called carbon monoxide. Carbon monoxide actually likes the hemoglobin molecule better than oxygen does. So it has a 200 times greater affinity, which we'll talk about here in just a little while. Another blown up area of gas exchange, this is the alveolar space. This is actually occurring in the alveolar space, and this is at the capillary level in the tissues. So O2 attaches to the hemoglobin molecule, gets transferred to the tissues or brought out to the distal tissues. The hemoglobin molecule, because of the actual acidity change, because of CO2, as CO2 rises, it makes this area have a little more hydrogen ion concentration. This is going to offload the oxygen into this area. That's how the hemoglobin knows how to offload the oxygen, and vice versa. And it will pick up the CO2 that's there. It disassociates pretty quick because we have something called carbonic anhydrase on this red blood cell, and it will quickly make, it has bicarbonate and hydrogen, which will make carbonic acid. This maneuvering, or this chloride shift right here, allows the bicarbonate to be offloaded so that the buffering system of the body actually works quite well and efficiently, very rapidly. Bicarbonate buffer system. It picks up the CO2 and then will carry it back. So when it carries it back, which is over here, the CO2 is dropped off and the oxygen is obtained. And this happens all over again. So alveolar, distal capillaries, gas exchange, higher to lower, gas exchange, higher to lower. Clinical notes: chronic respiratory diseases. Obstructive lung diseases are pretty much two diseases combined together for more than 6 months. Emphysema and chronic bronchitis and asthma are all separate diseases. So someone with COPD can actually have any of these three. If they have both diseases for more than 6 months, then they have chronic obstructive pulmonary disease. That's why you get variations of people that have lung disease. They can have emphysema, which is pretty much the destruction of the alveolar walls. The alveolar walls actually trap gas. The proper term for someone that has subcutaneous emphysema, the proper term for it would be subcutaneous emphysema. Whenever we say that someone has emphysema, the proper term for that should actually be alveolar emphysema. Emphysema means trapped air. So these patients actually trap air in the alveolar sacs. Now, what that does is that decreases the amount of oxygen and gas exchange that's occurring. Chronic bronchitis. Increased number of goblet cells in the bronchial tree, and the goblet cells are pretty much mucus producers. These guys are going to make thick, tenuous mucus, which will actually, they can cause some emphysema as well, or air trapping from that thick, tenuous mucus. Or they can just interfere with surface area exchange, cause bronchospasm and all kinds of nasty little things. Asthma, chronic inflammatory disorder. Airway, 2 phases. One phase is bronchial constriction, which the actual lumen of the bronchial tree, and the cartilaginous rings that it has on there, spasms and becomes smaller. This is going to decrease the amount of air that we're moving through the pulmonary trunk. And then there's a phase 2 to that, which is inflammation. Due to this constriction and the decrease in airway size, inflammation actually occurs and swelling of the actual bronchial tissues. Status asthmaticus, last but not least here. Repeated prolonged asthma attack that cannot be broken by bronchodilators, and this would be one asthma attack after another, after another, after another. So we have to get ahead of this, and we have to be able to provide airway support to someone that is in status asthmaticus. Upper respiratory infections, or URIs. Infection of the lung tissue secondary to a virus or a bacteria. And this can be worsened by chronic lung disease. If you're continuously have mucus that is built up in your lung tissue, does it make sense that this could harbor a bacteria very, very easily? Or a virus? Clinical notes, pulse oximetry. 98% of the oxygen is carried by hemoglobin. 2% is carried by the actual plasma that the red blood cell runs around in. It would be possible to moderately oxygenate somebody in the effects of hemoglobin or carboxyhemoglobin or carbon monoxide poisoning. So if we change atmospheric conditions, instead of 21%, we give them 100%. We've changed it almost 5 times. Or we have changed it at least 5 times. 5 times more push from the oxygen would supersaturate the plasma and may facilitate the ability for us to oxygenate their distal tissues until we get them to a place that has a hyperbaric chamber. Carbon monoxide poisoning. Carbon monoxide has a 200 times greater affinity for hemoglobin than oxygen does. Treatment on this is going to be maximizing oxygen delivery to ensure that all available hemoglobin is oxygenated most of the time. The patient doesn't completely recover until they get new hemoglobin and new red blood cells. This is devastating to the red blood cell environment. Often patient must wait on new red blood cells production to make a complete recovery. We can facilitate this quicker by giving them cross-type and matched blood as well. Clinical notes, arterial blood gas measurement. This is going to be a general overview. Whenever we start talking about assessment, we'll talk about this again. These numbers have to be put to memory. pH 7.35 to 7.45, PaO2 80 to 100, PaCO2 35 to 45, and then bicarbonate 22 to 26. Now, an example of this, we'll do a couple examples here. The first thing that you should ask whenever determining an ABG is, what is the pH? Are they acidic or alkalotic? The second thing you should ask, does it have anything to do with CO2? The third thing, and this will just solidify everything, what is their bicarbonate level? All right. Patient's pH is 7.25, and if you need to review, this is in about chapter 2. Anything that is less than 7.35 is going to be acid. Anything that's over 7.45 is going to be alkalotic. These are your ranges. So first of all, 7.25, they're in some sort of acidosis. This patient's PaCO2 is going to be 65. And their bicarbonate level is going to be 25. So the next step on this, does it have anything to do with CO2? CO2 is readily formed into carbonic acid. So if their CO2 level is high, the patient can quickly, very, very quickly form carbonic acid and become acidotic. If it has something to do with CO2, or if there's a high CO2 level and it's changing their pH, then you should consider them to be in respiratory acidosis. So this patient here has high CO2 levels over 45. Those high CO2 levels would make them a respiratory. The third thing on here is this is correlated between metabolic acidoses or acidoses that are not caused by CO2. The bicarbonate buffer system is what pretty much adjusts your acid-base derangement very quickly at the cellular levels. So a person that has a normal bicarbonate level would not be depleted. So this person here has no metabolic acidoses. So the answer to this patient, are they in a respiratory acidosis or metabolic acidosis, is they are in a respiratory acidosis. Let's clean this off and do a couple more here. Okay, so next patient. Patient is 7.25 on the pH. The PaCO2 on this patient is 100. The PaCO2 is at 40, and the HCO3 is at 18. So first question, does it have anything to do, are they acidic or alkalotic? They are acidic. That's normal, that's normal, that's abnormal, that's low. So they have been using up bicarbonate ion. That means that it's another acid besides carbonic acid. So they are in a metabolic acidosis. All right, one more here. We're going to go alkalotic side. So patient's pH is 7.55. PaO2 is at 200. PaCO2 is at 12. And the HCO3 is 25. All right, first question, are they acidic or alkalotic? They're alkalotic. Does it have anything to do with CO2? They don't have enough CO2. So they probably breathed off too much CO2. They probably are going to be hyperventilating. Does it have anything to do with CO2 or bicarbonate? These are all, this one's normal and this one is dangerously low. So this would be caused by respiratory alkalosis. Okay. If you have any questions over acid-base, come to one of the Fridays and we can talk all about it. The control of respirations. The control of respirations, the control of the respiratory centers of the brain, reflex control of respirations, hypoxic drive, lung cancer, capnography, SIDS, and the control by higher centers are what we're going to talk about in this section. The control of respirations. Cells absorb oxygen continuously. Homeostasis maintains equilibrium. Homeostasis involves changes in blood flow and oxygen delivery under local control. And 2, changes in the depth and rate of respiration under the control of the brain's respiratory centers. Local control of respirations. The rate of pickup at the lungs and the delivery at each tissue are controlled at the local level. If the tissues become more active and PO2 levels fall, the PCO2 levels rise. These changes cause a difference in the partial pressure. This signals to increase airway size and decrease PCO2 levels. So very simply, if you have a rise in CO2, your body is triggered, oh my gosh, I got to get rid of that, so your respirations increase. Controlled by the respiratory centers of the brain. Respiratory centers located in the pons of the medulla oblongata. The medulla oblongata sets the pace and the rhythm and the pace of respirations. The reflex control of respirations. Inflation reflex prevents the lungs from overexpanding during forced breathing. Deflation reflex inhibits the expiratory centers and stimulates the inspiratory centers when the lungs are collapsing. Herring-Bear's reflexes, inflation and deflation. Reflexes together are known as this. This will also stimulate the glossopharyngeal and vagus nerves. If we need somebody's heart rate to decrease because it's going too fast, one of the vagal maneuvers that we could try is to have them blow on a 10 cc syringe. The blowing on the 10 cc syringe pretty much increases vagal stimulus by stimulating Herring-Bear's reflexes. Higher brain centers, and this is the respiratory centers of the pons. We also have, as far as control here, we have this nice little fold occurring of our subdural area, and the CSF chemoreceptors pretty much are located in this area as well, in the cerebellum. If they become higher concentration of CO2, then they'll increase respirations. This is all done by the dorsal respiratory group. We have ventral respiratory group as well, which means anterior here on the front. Now, what these do is these things pay attention to chemoreceptors and baroreceptors. And remember, the baroreceptors are pressure. Chemoreceptors are looking at CO2. And then this is feedback off of the stress receptors on the lungs. So if you've taken too much air in, let's slow things down a little bit so that we don't get ahead of things. We get motor neuron responses, both on the diaphragm and on the intercostal muscles. All of this is what helps us control and rhythmically breathe. Clinical notes: hypoxic drive. Respirations are controlled primarily by the amount of carbon dioxide. In chronic diseases, this gets flipped secondary to high CO2 levels. So if you have continuously high CO2 levels, you won't be able to trust CO2. So your body switches to something called a hypoxic drive. Flipping to oxygen levels is called the hypoxic drive. Given long-term oxygen can cause respiratory arrest, and that's because if they have flipped over to running off of O2 or have a hypoxic drive, and this is going to be chronic lung patients, COPD, asthma, emphysema, chronic bronchitis. If they have flipped to a hypoxic drive and you give them long-term oxygen, tons and tons of oxygen, you can actually put them into respiratory arrest. Now, there's a point on this. In the acute setting, as far as EMS is concerned, if the patient is hypoxic, we never withhold oxygen from a hypoxic patient. We should initiate oxygen, oxygenate them to the best of our ability. If we knock out their respiratory drive, then we should intubate them and take over. Lung cancer. There are 4 types of lung cancer. Adenocarcinoma, which is cancer mucus-producing cells in the lungs and bronchioles. Small cell carcinoma, and this cancer pretty much arises from the bronchial tree. Epidermoid carcinoma arises from the bronchial tissues. Large cell carcinoma arises from the bronchial tissues. Both epidermoid and large cell carcinomas pretty much have a bad prognosis. So if you get these are generally very aggressive forms of cancer or carcinoma. Capnography, clinical notes on this. Now, if you'll just take a look at this, this is a capnographic waveform that we're looking at here. And if you think about a respiration flipped upside down. So phase 1 is late inspiration, and that's down here. We'll kind of talk through these first, and then I'll explain each one. Phase 2, the appearance of CO2 in the exhaled gas. That's here. Phase 3 is the plateau, and that's this entire area that we're looking at here. And then D is going to be the peak of that. And then phase 4, rapid descent during inspiration. So again, this is kind of like a flipped inspiration. This is whenever you're actually inspiring oxygen. This right here is whenever you start to expel CO2. So the capnography, or the capnometer, starts to register expelled CO2. At the point that we get to C in this, we start the plateau. Now what this plateau is this is the amount of time that we're expelling CO2. D is going to be the highest amount of CO2. This is where we're going to get our number on our capnometer. So examples of that, the capnography levels or the CO2 levels should be 35 to 45. They should coincide with what we see on the ABGs. Let's say that this patient's highest amount that they put out was 39, and that's from this side over here. That would be within the normal range. And then whenever inspiration starts to occur, we go into phase 4. And that plummets the amount of CO2 that we're seeing in the sample. And this starts all over again. This is phase 1. 2 would be here. 3. And there's not enough room to do phase 4. But we would see this again and again and again. And this is capnography. Clinical note, SIDS. Leading cause of death among infants. Cause is pretty much unknown on this. Occurs more frequently in the fall than in the winter. And boys are more affected than girls. Sudden infant death syndrome. Controlled by higher centers. Higher centers influence respirations through their effect on the respiratory centers of the pons. And this is going to be where the respiration is controlled. The contraction of the respiratory centers can be voluntary, suppressed, or exaggerated. Depth and rate can also change when involved with rage, eating, or sexual arousal. These changes are from the limbic system and occur involuntarily. Respiration changes at birth. Before delivery, your pulmonary vessels are all collapsed. Pulmonary arterial resistance is pretty high. The rib cage is compressed, and the lungs and conducting pathways contain only a small amount of fluid in them. So they're not expanded yet. They've never taken a breath of air. At birth, the newborn takes their first breath. The rib cage expands and does not recollapse from cartilage and connective tissue. What this allows for the normal piping that we know today to occur. So now we get pulmonary shunting occurring correctly. Most of the holes close up or start their closure procedures. Pathologists use this as a physical change to determine if the newborn died before delivery or shortly thereafter. And how they figure that out is there will be residual volume in the lung tissue. So the baby, if placed in water, will actually float. If they've never taken a breath, they're going to be solid. They're going to appear as solid tissue when trying to place them into water, and they will sink to the bottom. Aging in the respiratory system. Very simply, chest movements are restricted due to arthritic changes in rib articulations. As you get older, things don't move as well. Decreased flexibility, muscular weakness, stiffening and the reduction of chest movement, decreased vital capacity and pulmonary ventilation. Some degree of emphysema is normal in individuals over 50, varies due to exposure to cigarette smoke. Whenever we're looking with integrations of other systems, the respiratory system integrates with every system. It's what oxygenates it, it's what allows the movement of oxygenated red blood cells to the distal tissues. Terms we should know, please look over these and be aware of them. Alveolus, alveoli, which is going to be the actual sac when your gas exchange occurs. Bronchial tree, bronchial, bronchus, bronchi, all of those are airways from small to large. Larynx, voice box, lungs, where gas exchange occurs. Nasal cavity, which is going to be just above the oropharynx. Partial pressure, this is the pie. Pharynx, oropharynx and pharynx, tongue, teeth, respiratory membrane. We're talking about the alveolar sac with the capillaries running across it. Respiratory rhythmic centers, pons of the medulla oblongata. Respiratory system, everything that we've talked about in this chapter. Surfactant. In the alveolar sac, you have surfactant that allows this alveolar sac to stay open, and it allows for surface tension to occur and then to exchange gases. Without surfactant, this would collapse and kind of collapse in on itself. Trachea, airway, large airway before the bifurcation or the branching into the left and right main stem. And then vital capacity, which is the sum of the inspiratory and expiratory reserve volumes. If you have any questions on this, please feel free to contact me, Roy Smith, 405-219-7613, or you can drop me an email at smith@imsa.net. Thank you.